Hi, everyone. My name is Dr. Brittany Dunn, and this is our synchronous session for the day. We're going to be talking about common pediatric anti-infectives. My hope is that this could just be a quick guide for when you're in practice and wondering how you should treat children with some of these common ailments. So our objectives for the day are listed here. We're going to talk about an overview of common pediatric conditions that warrant the use of anti-infectives. We'll also discuss when anti-infectives are not indicated, and we'll talk about a few of the common side effects of some of the typical drugs that we use in the pediatric population. So here's the topics we're going to explore. It's kind of your, common offenders for why kids will have a sick visit to the pediatrician office. You've got acute otitis media, ear infection, strep pharyngitis or strep throat, bacterial conjunctivitis, impetigo, common cellulitis, rhinosinusitis, Candida, and then a urinary tract infection. I also, for all of my presentation today, I'm using the 8th edition of the Burns Pediatric Primary Care textbook by Garzon et al., and I'll have the reference at the end of the presentation. So we'll start off with acute otitis media. This is something that you will see a ton in practice. So what is it? It is inflammation of the middle ear. Your diagnosis can be made if the following 3 criteria are present. So that would be a recent sudden onset of middle ear inflammation. So that could be otorrhea, erythema, or ear pain, and they might or might not have a fever. They should have some moderate or severe bulging of the TM, which you can see in this picture here. It's definitely bulging. It's red. You can see that purulent drainage behind it. And then it should be a symptomatic infection. So they're, pulling at the ear, they're holding it, they're rubbing it, they're saying it hurts. So we're continuing the what is it. Common causes, it can be viral for sure. Usually it's going to be flu or RSV that are your offenders. And then a lot of times it will progress on to bacterial or, bacterial and viral combination. Strep pneumoniae is the most common etiology. You also will see a little bit of H. flu and catarrhalis. Those are all some of our common bacterial reasons for an ear infection. And we're going to treat these because if you have chronic untreated episodes, it can cause hearing loss in some kids. It can also progress to more widespread illness, like you could have mastoiditis, which is infection of that mastoid bone. And obviously, you're close to the brain, so you don't want to let a severe infection go. We'll talk about reasons that you might not treat in a few minutes. And just for your reference, H. flu is the most common cause of bilateral otitis media and really severe TM inflammation. But we are seeing less and less of H. flu because we have the vaccine now. So when do we treat it? You're going to treat any kid with symptoms or if they're very young. So any child who's got really severe bulging of the tympanic membrane, if they've got otorrhea, they've got that drainage from the ear, any child with some mild bulging, and then they've had, pain onset recently or very, very inflamed tympanic membrane. And then if they're over 6 months, with severe signs of infection, so that means a high fever, really severe pain for over 48 hours, you should treat them. And then any child who's under 2 but older than 6 months with acute bilateral otitis media without severe symptoms, it's still worth treating. So if they're under 2, you're going to go ahead and treat them because you're worried about, language development. If they're a little bit older, you can do more of a watch and wait. So that's what we're talking about here. So when do we pause? So if they're over 2, they have an ear infection on one side. Symptoms aren't very severe. Their fever isn't over 102.2. Then you can wait just a little bit and see if their ear infection resolves on its own or if it gets worse. So the next bullet point is basically saying the same thing. So no severe symptoms, but they're over 2. You can kind of watch. So the way that this works is you could give them a paper prescription and say, hey, if this gets worse over the next couple of days, you can go ahead and fill this prescription. Meaning if their fever doesn't go down or if the pain continues, if the child seems really uncomfortable, treat it. You could also have them come back in a few days and recheck the ear and see how that's looking. And then you might or might not treat from there. It's really important, though. You can only do this with families that you trust, and you feel like they're pretty medically savvy, because we're always worried about antibiotic resistance. And I worry about families who will take a prescription, go ahead and fill it, and then maybe save that medication for another day. And really, it might not be the proper antibiotic for whatever they have going on down the road. So you really have to do a lot of good education here. But I like it because, we don't want to treat things that we don't have to. But I would just make sure you have a really good education piece laid out for your family, and make sure they understand when they should use it and when they should not. All right, so how do we treat it? So you can treat it orally, and then you can also treat it through drops in the ear. Your first choice is going to be amoxicillin. Typical dose is 80 to 90 mg per kg per day, divided BID. And then I have some more specifics listed here. But basically, if they're very young or have very severe symptoms, you can do 10 days of treatment. If they're 2 to 5, mild or moderate symptoms, you can do 7 days. You could do a little bit less if they're over 6. You also could treat with Augmentin. It's good because it provides that beta-lactamase coverage. It's a little bit broader spectrum. It can cause diarrhea. Pretty much all of your antibiotics can cause diarrhea. You also have the option of your 3rd generation cephalosporins. I really like Cefdinir. It's once a day dosing and it's helpful. You could also use ceftriaxone. The con is it's an IM administration. That could be a pro as well if you have a kid who has a hard time taking medications. And then these are also an alternative if they have a penicillin allergy that is not a anaphylactic allergy. You could also use clindamycin, but you should really only use this if you have a culture insensitivity. And then remind parents too, this is just good NP knowledge, but remind them that they should complete the entire course of the antibiotic. A lot of times they'll say, oh, we took it a few days and then they felt better, so we stopped. That's a good time to discuss antibiotic resistance and why we all have to do our part and make sure we treat an infection completely. A few other things to mention on this slide. Cefdinir, the one that I said that I like, it can cause red stool. So just make sure you explain that to families. It can be pretty alarming. They might think it's bloody stool, but just explain that, the medication. And then cefuroxime, it tastes terrible. So just make sure families are aware of that. And that could be a reason to not prescribe that medication if it's not going to be tolerated. All right, so this is not a typo. You can treat with ototopical and ophthalmic drops. They do go in the ear. If they have a perforated tympanic membrane or if they have tubes, then this would be your go-to option. So you can use ofloxacin, ciprofloxacin, or tobramycin or gentamicin. And then, of course, always remember that we are going to treat with symptomatic relief as well. So, if they need ibuprofen, Tylenol, those are always good options too, just to treat for patients being uncomfortable. All right, and then also one other thing to mention, if they have recurrent ear infections, so more than 4 in 6 months or more than 6 in a year, it's probably time for tubes, and you should definitely refer them to ENT at that point. All right, so that kind of wraps up acute otitis media. Obviously, you should always pay attention to resistance within the area that you live in when you're prescribing medications and prescribing antibiotics, but those are our typical first line and second line. So moving on, we'll talk about strep pharyngitis, strep throat. Everybody has probably had it at some point. We're all familiar with it. So it's inflammation of the mucosal lining of the throat caused by group A beta hemolytic strep. It is the most common cause of pharyngitis and tonsillitis in children, especially that school age group. Why do we treat it? Well, we know that if it's untreated, and especially if treatment isn't initiated within 9 days of symptom onset, you increase your risk of rheumatic fever. So that's what we're really trying to avoid. There are a few other post-strep sequelae to mention. So PANDAS, PANS, post-streptococcal reactive arthritis, acute glomerulonephritis, peritonsillar abscess. These are all things that we look out for and are good reasons to treat for strep throat. So how do we treat it? Your penicillins are your bread and butter, first line. Pen-BK, amoxicillin, benzathine, penicillin, G are all versions of penicillin. Amoxicillin is definitely the most prescribed probably. Your children like the taste, it's easy to take. If they are penicillin allergic, you could use Keflex or cefadroxil, clindamycin, azithromycin, chlorothromycin. Again, make sure that we're treating with supportive care. So that means treating a high fever, using pain medications, fluids, rest, soft foods, the things that we know to tell our families that are beyond just here's the antibiotic, but make sure that you're treating all the other symptoms as well. And then notice that a steroid is not indicated here. So moving on, this just makes my eye itch whenever I look at this picture, but we're going to talk about bacterial conjunctivitis. If you have children, you're familiar with the term. So what is it? It is the most frequently seen ocular disorder in pediatric practice. Bacteria are the most common cause in children. So it's like 50 to 75% of cases usually starts on one eye, can travel bilaterally. And it occurs typically December to April, although obviously it could happen at any time during the year. Your kids who are going to be most at risk are definitely your daycare kiddos. Your most common pathogens that we'll see are H. flu, strep pneumoniae, Moraxella, I have a hard time saying that word, Moraxella species, Staph aureus, and then gonorrhea. I mentioned that we definitely see it in our preschoolers, daycare kids. You can also see it in neonates and sexually active teenagers. If you do see it in a neonate, you should culture. All right, so how do we treat it? We are going to treat with trimethoprim, polymyxin B solution for 5 to 7 days, or erythromycin for our infants or if they have a sulfa allergy. If they're over 1, you can do a 4th generation fluoroquinolone. And then a lot of times we'll see these in conjunction with a ear infection and AOM, so treat those as well. They should have warm soaks to the eyes, TID. Super important to educate families that you can't just take a warm compress from your infected eye, then put it right on your non-infected eye, because then you will quickly have 2 infected eyes. So educate that they should wipe the eyes with warm water and then use a clean rag on each eye. Same thing if they're using eye drops, make sure they don't actually touch the eye, because then you're just going to cross-contaminate. Let's see what else. It's also important to remember that it actually is typically self-limiting and it'll resolve after like 8 to 10 days in most people. However, we usually do treat this because it can affect when patients can go to work, when they can go to school. I mean, 8 to 10 days is a long time to stay away from people, so we do go ahead and treat these patients. Also, it's very uncomfortable to have your eye just draining and itchy. Something else to mention, we do try to avoid aminoglycosides now, just because we've seen a lot of resistance and then some allergic reactions with it as well. They should not go back to school or work until treatment is initiated. Don't wear any contacts during treatment. I always say throw out all the makeup that they were wearing, just to get rid of any cross-contamination. All right, next is impetigo. This is a bread and butter board question, because if you see honey-colored crust, they're almost always talking about impetigo. It's a common contagious bacterial skin infection. It can be non-bullous, which is typically what we see, or bullous, which is the more severe form. Usually it's called by Staph aureus. That's the most common, or strep pyogenes we also see too. You're going to treat it most commonly with Keflex, Augmentin, dicloxacillin, or Clinda if they are penicillin allergic. And this guy, you can see he's got that honey-colored crust. This is so typical. It is important to mention, so I didn't say just amoxicillin. I said amoxicillin clavulanate or Augmentin, because you do need that beta-lactam coverage. And you're going to treat for 7 to 10 days. Now, if they have a really severe infection, it's possible that they could actually need parenteral treatment and be admitted for it. So this can be pretty severe in some patients. Typically, though, you're going to see a patient who looks kind of like this. All right, next we're going to talk about common cellulitis. Now, this is one there's a spectrum. You know, you can have a simple cellulitis of the fingernail versus a very severe skin infection that leads to sepsis. So you really do have to pay attention to what your patient looks like, and treat clinically, obviously. So let's see, most of the time we can treat outpatient with just an oral antibiotic, but sometimes they do have to be admitted for parenteral treatment. And we're just going to kind of treat empirically here versus culturing every time. The reason being, if you culture something on the skin, you have so much bacteria on your skin as is. You know, it's hard to know if you're treating exactly the right thing. So now, if they're a very severe patient who is going to get admitted, then you should probably have that wound cultured. But for your typical primary care patient who walks in, you don't have to culture. So what is it? It is a localized bacterial infection of the dermis and subcutaneous layer of the skin. Usually it'll happen after, you know, a kid comes in, they get a bug bite or they scrape their knee on, you know, on the ground or whatever, and then it becomes infected. So you do culture if there is purulent drainage, if it looks really angry, or if you suspect MRSA. Those are good reasons to culture. But usually it's caused by strep or staph. Could be a whole bunch of other things though. So we're going to treat for staph and strep mostly. So you've got, again, Ceflex, dicloxyphilin, PenBK, Augmentin, Bactrim, if you need that MRSA coverage, and clindamycin if it is a severe infection or you need MRSA coverage. So if you have Clinda, like say that they have an infection that is in a sensitive place, then it probably would be a good idea to treat with Clinda at that point. So you kind of have to use your clinical judgment here. And then I would tell patients just to watch it really carefully because these things can get pretty angry pretty fast, and sometimes they need to be drained. So you could possibly do that in clinic if your clinic does that, or sometimes you have to refer to a surgery center if they need more pain control. All right, we're moving on. So rhinosinusitis is next. You are going to see plenty of this, and this is the one, if you see come through your office, you're going to need to educate because people always want to get rid of their sinus infections quickly. Obviously, they're uncomfortable, but a lot of times treatment is actually not the correct option. So treatment with an anti-infective, I should say. So what is it? It is a inflammation of the sinus mucosa after an upper respiratory infection. Might be infectious, it might not, can be acute or chronic. It's worth it to mention that chronic rhinosinusitis by the book lasts longer than 12 weeks. So that is a very long time. So very few people actually have a chronic sinus infection. Your common pathogens you'll see are listed here. And then the question is, okay, do we treat it? So here's your criteria according to the Guards-On textbook. So if they have a URI that worsens or you have new onset of symptoms, so they say, you know, I got sick 5 days ago, then I was feeling a little bit better, and then I just felt horrible again, and I got a strong or a high fever again. That's a reason to treat. If symptoms last longer than 10 days, that is worth treating. Now, I will mention a post-viral cough can last up to 6 weeks. So, you know, if they just have a chronic cough, but everything else is resolved, I don't think that's worth treating at that point. And then also if they have severe symptoms, so a high fever over 1022, if they have purulent nasal discharge for, you know, 3 days or more, then you can treat. But really the vast majority of cases don't fall into this criteria. So you just have to educate. And then also, this is my pet peeve, but people will come in and they'll say, well, you know, I have this green drainage, so it must be bacterial. That is false and not true. That fact alone is not enough to treat. So we just have to really take the time to educate our patients and explain, you know, why it's important to not treat every single infection with an antibiotic if our body can heal on its own. So always recommend supportive care. It also makes our patients feel good that, you know, we're offering them something, even if we're not offering them prescription, but, you know, give them some good supportive care. So humidification is important. A good nasal spray is important, saline nasal spray. You know, they should rest, they should drink plenty of fluids. All these things are important. So this is another time that you could watch and wait. And then, give it a few more days. Say, you're here on day 7. Let's give it 3 more days. If you still are having severe symptoms, then fill this antibiotic and let's treat it. Again, that can only be with a family that you trust well. So if we do treat it, you can do amoxicillin, Augmentin if they are susceptible to more severe symptoms. So if they're under 2, they go to daycare. If they've recently used some other antibiotic, or if they do have severe illness, then I would do Augmentin to get that beta-lactam coverage. You could also do ceftriaxone IM if a kid is vomiting or has a hard time taking medications. That's a good option. You also can use a 3rd-generation cephalosporin. So in the case that we are treating, we're going to treat for 10 days, actually. They should be asymptomatic by day 7. If they're not, they should call you and it might be time to switch antibiotic coverage. Yeah, so that's rhinosinusitis. All right, hang with me. We got a little bit left. So next we're going to talk about oral candida. It is also thrush. Here's a great picture of it. This is really common after recent antibiotic use, actually, or if they recently used steroids, or if they have asthma and they've used an inhaled steroid, they are very susceptible to oral candida. It's also common in healthy newborns. This is so gross, but it is, you'll see it because it's a white adherent. It does look like cottage cheese lesion with a really red base in the mouth. There's a few ways to treat it. You can do oral nystatin suspension. If you're worried about resistance, you could also do an oral fluconazole or clotrimazole troche. It's also important to mention if a baby has it who is breastfeeding, you should also treat the mother. So she should put, if you're prescribing nystatin, she should put some of that on her nipples as well to eliminate reinfection. Because you can see, you might treat the baby and then they just go right back to the source of the infection and you're starting back at square one. Next is cutaneous candida. So this would be like your diaper dermatitis, super, super common. It's an overgrowth of candida on the skin. In the event of diaper dermatitis, you'll see these characteristic satellite lesions, and it spares the skin folds. Super bright red erythematous, and you are going to treat it with a topical antifungal. So you need to apply it at every diaper change until it's gone for 1 or 2 more days. Typically, we'll do nystatin, miconazole, clotrimazole, ketoconazole. All right, and then finally, we'll talk about urinary tract infection, or UTI. So what is it? Obviously, an infection of the urinary tract. So typically caused by E. coli, but there's a few other reasons that we could have a UTI as well. Most UTIs are ascending, meaning they start distally at the urethra and they move upward. And they get more severe the higher up they get. So you could have cystitis, you could have all the way up to pyelonephritis. And they're, again, getting more and more severe the higher it gets. So hopefully we catch it before it turns into full-blown pyelonephritis affecting the kidneys. Let's see, it's much more common in females than males, more likely during infancy or potty training or in sexually active adolescent females. So I kind of touched on this a minute ago, but there are 3 subtypes of UTI. You could have asymptomatic bacteriuria, which means there's presence of bacteria in the urine. Like if you did a UA, you'll see some loops, but the patient has no symptoms. So in that case, you actually don't have to treat. If they're your typical patient who is otherwise healthy, not a baby, then we don't have to treat. The next step up would be uncomplicated cystitis. So in this case, you would treat for 3 to 5 days in kids over 2 who otherwise are healthy. You might need to treat for longer, so a week or 2 in children who are between 2 months and 24 months, or if they are febrile from a UTI. And this would be a patient who has evidence of UTI on their urinalysis, and they also do have symptoms. So they might have dysuria, frequency of urination, foul-smelling urine. These are all reasons to treat. And then finally, our worst case scenario is pyelonephritis. So in this case, you do absolutely have to treat. Interestingly, we found that oral treatment is just as effective as parenteral. But some people do have to be admitted, not so much for the antibiotic, but more for managing that fluid status, like getting enough fluids in to kind of flush their kidneys. Now, if they're under 2, pyelo is a really common significant bacterial infection when fever of unknown etiology is present. So in those kids, it's pretty common for them to require a catheterization because you want to have a really good urine sample to see what you're dealing with. So basically, when treating, you need to think, how sick is this kid and how old are they? And that'll help you kind of decide what you need to do. And then, as with everything, make sure you're paying attention to your regional resistance. And then also send a culture and sensitivity to make sure you have the correct antibiotic for that patient. So how do we treat it? So again, if they're asymptomatic and they're otherwise healthy, you actually don't have to. If they have uncomplicated cystitis, then you will treat with a few different options. You could do trimethoprim sulfamethoxazole, which is Bactrim or Septrim. You could do amoxicillin, cephalexin, or nitrofurantone, which is also macrobid. Now, if you have pyelonephritis, you're going to need that beta-lactam coverage. So Keflex, I should have put a slash there, sorry, Augmentin or ciprofloxacin are a few options that we have. If you have a patient who has recurrent UTIs, you should absolutely refer them to urology. You want to get their input and make sure you're not missing anything anatomic. They could have like a reflux situation. You just want to make sure that you're not continuing to just treat a UTI. You need to get a specialist involved. Let's see. Yeah, and remember, these antibiotics, they're starting points to cover for what we typically see, but you really need to get that culture and sensitivity. And, once that comes back, you need to narrow down your coverage for antibiotics. And this is just a very brief general side effects to watch for. There's so many that could be listed. You really need to make sure you're familiar with the medication that you're prescribing to patients and give them that anticipatory guidance. It's going to eliminate more work on the back end when they call you and say, oh my gosh, my kid's on Ceftonir and their stool is red. What do I do? If you've already told them, you're not going to get that call. And it's going to make the family feel more comfortable. They know what to expect. They won't freak out. And then also it'll help them know like what's a normal side effect and what is not normal. So if they have a true allergic reaction, if they have angioedema, if they have a really severe skin rash, they need to know that's not normal and they need to stop the medication and call you immediately. So really take the time to educate your families. So side effects to watch for, definitely diarrhea with pretty much all of them. C. diff can happen. That would be a more severe sequela of taking antibiotics. You could also have, like I mentioned before, allergic reactions, really common in sulfa and penicillins. So make sure you ask about allergies before you prescribe and then discuss what that might look like. Discolored stools I've touched on already. They could definitely have thrush. Could definitely have nausea and vomiting. And then some medications, you'll need to monitor lab values as well. This is more common in like antifungals. So just keep this in the back of your mind when you're prescribing a medication. It's not so simple as like, here's your amoxicillin, get out the door. There's more that you might need to talk to the family about. You also need to pay attention when you're prescribing to how frequently am I dosing this medication? Is this going to be tolerable for the patient? So just make sure you take the time to really think through what you're prescribing. Does it make sense for the patient? Is it a reasonable dose? Is it a reasonable frequency that they can actually take it? And then can they tolerate the medication? Okay, guys, I think that is really all that I have. Let me go to the next slide. Here's my reference. I used the Burns Pediatric Primary Care textbook. It's a really great resource. I highly recommend. And thank you, guys. I really appreciate it. Like I said, it's kind of brief, but I hope that it can be a good resource for you as you're in practice one day. And you can use it just when you're with your patients. So thank you so much for listening, and I hope y'all have a great rest of the semester.